This is Lauren Stiles. I am president and co-founder of Dysautonomia International, and I'm really excited this evening to have all of you joining us. We're joined by a special guest, Dr. Satish Raj, who's a professor of cardiac sciences at the University of Calgary and the director of their cardiac arrhythmia unit, if I got that wrong, sorry. And he's also a longstanding, very active member of Dysautonomia International's medical advisory board. And he's the guru of POTS blood volume. So we're going to get a great lecture tonight. Just a little housekeeping notes. There is a feature on Zoom where you can type some questions into the Q&A. I think it's scroll down towards the bottom of your Zoom panel. And so we'll try to get to as many questions as we can at the end, but generally speaking, there's usually way more questions that we could possibly get to in one evening. So please try to keep your questions general, something that would apply to a lot of patients. Dr. Raj can't give individualized medical advice over Zoom. We're going to record this. So if there's anyone who couldn't catch the whole session, then they'll be able to catch a recorded copy later. So with that, I do have to thank our sponsors too. One sec, there we go. I wanted to thank Dysautonomia International sponsors, all of whom have great products that can help you increase your blood volume. Liquid IV, Vitasium, and Normalite are all good salty hydration products. And they're generous sponsors of Dysautonomia International throughout the year, and they help us put these webinars on for free. So I'm done with my slides, and Dr. Raj, you can start to share your screen now.
Great, thank you, Lauren. Let me pull this up quickly. So thank you again for joining in what is evening for most of you. I'm going to touch on different things and happy to try and answer questions if there are sort of more detailed aspects. And I've taken a fairly expansive view of what blood volume can do, but also what approaches we have to improve or alter it. So I'm not going to belabor the point. I suspect that if you're all here, you already have a good basic handle on POTS. This is a slide I've used before, just showing a tilt table response in a control subject on the right and a POTS patient on the left. You can see that there is the heart rate channel on top, a blood pressure channel, a continuous blood pressure channel in the middle, and a tilt angle, when you can see when the table's up and the table's down. And the key thing here is that POTS isn't primarily a disorder of low blood pressure, certainly. The blood pressure trace may look a little different from the control subjects. That may be important, but the real money here is in the top channel, the heart rate channel. When the control subject stands up, the heart rate goes up, right? So the key thing here is the heart rate increasing isn't in and of itself abnormal, but you can see the POTS patient does it a lot better than the control subject. This patient didn't make it through a full 30-minute tilt, which is the protocol we were looking at, because she basically had enough. And when she told us to put the table down, her heart rate was almost 180 beats a minute. Now, the truth is that most of our patients don't get their heart rates that high, but it obviously is excessive and can be incredibly excessive, as in this case. And importantly, this is associated with a bunch of troubling symptoms to patients, and they can be broken down in different ways. If you had a neurologist giving this talk, they may break it down differently, but as a cardiologist by training, I've broken them down to symptoms on the left that could plausibly be attributed to the heart. Racing heart, palpitation, chest discomfort, shortness of breath, lightheadedness, and symptoms on the right that I have a lot more trouble directly blaming on the heart or cardiac function per se. Brain fog or mental clouding is incredibly common. Headaches, very common. Nausea, very common. Tremulousness or shakiness are very common. And again, most of these symptoms in black here on both sides tend to be worse with upright position. But there are some symptoms that aren't positional. So sleep complaints, very common. Fatigue, very common. Exercise intolerance, very common. And I'm not sure the blood volume is the be all and end all for all of this, but it certainly, I think, can help with some of the cardiovascular symptoms and in some cases, some of the other symptoms as well. in summary, the symptom burden is fairly high in POTS patients. This is from the same study where we had the tilt data from a couple of slides ago. And what we see here during this 30-minute tilt is the control subjects in black, for the most part, are asymptomatic. Occasionally, someone will become slightly symptomatic and then they faint, and then they sort of drop out. And so you see numbers going up marginally and then flipping back down. The POTS patients, on the other hand, in red, quite symptomatic from right in the beginning of the tilt, and it really stayed that way all the way through. Interestingly, a higher proportion of the POTS patients made it through the full 30-minute tilt than the control subjects. Right, so think about that. The POTS patients felt like they're going to faint throughout the tilt, but actually more of the control subjects actually fainted. So it just drives home the point that POTS, it's not that POTS patients can't faint, they can, a minority do, but it's POTS isn't primarily a fainting disorder, it's a feeling faint disorder, among other things. So that brings us to blood volume, and my interest in this dates back to, right at the beginning of my time working at Vanderbilt University under David Robertson. And we were interested in blood volume shifts in patients with POTS. And in that first study, we actually did a direct measurement of blood volume. This is something that's available typically through nuclear medicine labs clinically when they're available in the States. You can't get this from a simple lab test. And what we found is that we had a tool that measured the volume, and then we recognized that bigger people have more blood. So I don't know how many of you remember Andre the Giant, but if Andre the Giant, you compared Andre the Giant's blood to Lauren, his blood volume would be expected to be much higher because there's so much more of him. So the technique we used actually accounted for this. They used old formulas to estimate or predict what the blood volume should be based on someone's height and weight and sex, because the curves are slightly different for men and women. And based on that, we found with the control population on the left, you see here, there's a spread. I mean, not everyone's the same, but on average, the formulas were pretty good. There was really no plasma volume deviation. It was almost bang on. Whereas the POTS patients, on average, had about a 12% deficit in blood volume. So they're down, realistically, we're talking about a can of Coke, right? We're not talking about liters and liters down, but their blood volume was a little bit contracted, and we thought that might be part of the problem. So we actually looked at some of the hormones that regulate blood volume, and two of the hormones here are renin activity on the left and plasma aldosterone on the right. So aldosterone is a hormone that works on the kidney to retain sodium, and renin actually helps, as you'll see in a moment, indirectly to drive aldosterone levels. Now, if the blood volume is low and these components or this mechanism is not part of the problem, you'd expect it to try and be part of the solution. And what we'd expect is that the levels of the renin activity and the aldosterone, things that would try to work to increase the blood volume, would be elevated in the POTS patients with a low blood volume. But that's not what we found. What we found was that the renin activity was the same, or I'd say inappropriately low, and the aldosterone levels were really lower in the POTS patients than the control subjects, which led us to conclude that this may be part of the problem in some of these POTS patients that we were studying, is that their renin angiotensin aldosterone system might not have been working properly to fully hold on to the sodium in their kidneys. And this is just a little schematic cartoon of the pathway. So there's angiotensinogen that gets converted to angiotensin 1, and the PRA is the plasma renin activity. That's what I showed you on the prior slide. And that gets converted via the enzyme ACE, or angiotensin converting enzyme, to angiotensin 2. And then that works, activates the angiotensin receptor. And when it doesn't, the adrenal gland can produce aldosterone, and ultimately this promotes sodium retention and increases blood volume. So this is how things are supposed to work. And based on sort of where we were in 2005 after that first study, we found that the renin activity was on the low side, the aldosterone was on the low side, the blood volume was on the low side. And I submitted this to circulation, and the reviewer came back and said, well, yeah, that's great. You showed the aldosterone's low and the renin's low, but you ignored all the stuff in the middle with these angiotensins. And the reviewer was right. We sort of assumed that this is low on the left and it's low on the right, it'll be low in the middle. And the reviewer took pity on me, and we were able to get the paper published. But it turns out it may be more complicated. So over the next few years, Julian Stewart, who I'm sure many of you are familiar with from New York Medical College, published some work suggesting that he found in one of the subgroups of POTS patients that he was studying that they actually had a high angiotensin II level. And then he did some very nice work using a skin model, a microdialysis skin model, where he thought there was decreased ACE2 activity. And I will say until about 18 months ago, there were very few people I talked to that had ever heard of ACE2. That's changed because of COVID. But this is where that fit in. So ACE2, infections aside, its main historical role has been as an enzyme that degrades angiotensin II into angiotensin 1 to 7. It does a few other things, but that was its main role. And so we now had that Ang2 levels were elevated, and perhaps ACE2 levels were decreased in POTS patients. And in fact, we later showed as well that Ang2 levels were elevated in a paper that we published a little later on. As I mentioned, ACE2 has gained prominence in the last year because it turns out the SARS-CoV-2 virus, the virus that causes COVID-19, actually in the body binds to the cells via the ACE2 receptor and then gets in the cell that way. And so people have paid a lot more attention to it for that reason. This mechanism is entirely different than any COVID-related mechanism we think. And so we found that POTS patients had high angiotensin II levels, as you see in the top left. The breakdown product, angiotensin 1 to 7, was less high. And so if you look at ACE2 activity, basically the conversion from one to the other, it seemed to be low in POTS. So using blood tests, we showed similar findings to what Julian showed in his skin work in POTS patients. And then we also wondered about whether that receptor that triggers the production of aldosterone was not working properly or blunted in POTS. So the net result is lower aldosterone levels. And so that's sort of a lot of stuff summarized here. The key things that I think we're very confident about is that a lot of POTS patients, not all, but a lot, had low blood volume. There was low plasma renin activity, low aldosterone. So hormones, multiple hormones in that pathway, the renin angiotensin aldosterone pathway, were affected, but angiotensin II was high, suggesting that there may be a problem in its degradation or metabolism. But there ultimately was a paradox, because if they're high angiotensin II levels, it wasn't clear why they were low aldosterone levels, and there may be a separate receptor problem. Realistically, the net result of that is that there may be, this would all suggest that there may be a problem holding on to sodium in the kidneys of some of these patients. So that first set was just to point out that there's some data suggesting there may be problems there. So then the question is, well, how do we go about trying to increase blood volume or the effective blood volume? And there are different approaches that can be taken. I'm going to focus largely on non-pharmacological approaches and then touch just briefly on a couple of drug approaches used loosely. So first, dietary salt. I suspect that many of you out there that have POTS have been told to increase your dietary salt intake. And, I sort of joke with patients that they should just get a salt lick, and put it in their living room and lick it every time they go by, that really we are pushing salt in a very big way. But of course, this is countered by the fact that the American Heart Association in the US and the Heart and Stroke Foundation in Canada, and I suspect the British Heart Foundation, have for years made the point that as a society, we need to lower our sodium intake. And that's because they're dealing with the population health problem of hypertension and long-term risk of stroke. However, for our patients, that hasn't been the advice. We have seen low blood volume, and we've been trying to augment the blood volume, augment the salt intake in the hopes of increasing the blood volume. But I guess the question is, does that really happen? Um, so years ago, I was shocked when we were sort of designing a grant building on our aldosterone angiotensin work that I shared with you, that despite the fact that we'd been recommending high salt intake, there had been very little data published suggesting the sodium did what we thought it would do. So the rationale for increasing dietary sodium is that it would expand the blood volume. You'd hold on to the salt, the fluid in the kidneys would follow the sodium, and so you'd hold on to the fluid and expand your blood volume that way. That could then hopefully decrease the need for increased sympathetic tone. The crude measure that we use is measuring the plasma noradrenaline or norepinephrine levels in the blood. That we think is the driver in many patients for the high heart rates that we notice, especially on standing in POTS patients. And so by blunting this, that we could lower the amount the heart rate jumps up. And ultimately, the goal of all this is to see if we can improve symptoms, right? I, as a human physiologist, am very interested in the physiologic parameters. I know some of you are interested in that, but only the interest really is primarily to see if that's causing problems that we can then fix. And so this is a brief cartoon of the study design. This data has been many years in the making. It was actually presented first in 2014 at the Heart Rhythm Society meeting, and bits of it later at autonomic meetings. This is actually going to be published next week in the Journal of the American College of Cardiology. So the actual paper will be out almost momentarily. But basically, this is a study that took a fair bit of effort on the part of the patients that participated. So we had POTS patients and control subjects who agreed to come into our research unit at Vanderbilt for 2 one-week stays. During one of the stays, they were fed a very low sodium diet, as low as we could make it. And on the other week, the other phase, they were fed a very high sodium diet. And we randomized the order of that. And we actually tried to bring patients in at roughly the same phase of the menstrual cycle. So it was at least a month apart, in some cases a few months apart, because we know that there is cyclical variability in some of these hormones that we know are very important. And we looked at the things that we were talking about. We looked at plasma volume, we looked at norepinephrine levels, we looked at the effects of heart rate, blood pressure, lying and standing, the metrics that we use to assess how severe the POTS is, if you will. And this is what we found. So the data in the next few slides looks similarly in that the POTS patient data are in red, the control subject data are in blue. The hashed portions are on the high salt diet and the solid portions on the low salt diet. You can see that as before, the POTS patients we saw had a deficit of 12 or 13% in their blood volume on the low sodium diet. When we put them on a high sodium diet, it didn't eliminate the deficit, but it decreased it. It was down to about 4 or 5% on average, and that was a significant increase. We also were able to increase the blood volume of the healthy control subject from the low salt to the high salt diet. The high salt somewhat normalized, but did not totally normalize the blood volume in the POTS patients. In other words, the POTS patients on a high salt diet still actually had a lower blood volume than the healthy control subject on a low salt diet. Now, blood volume isn't one thing. It's actually two things largely. There's the red cell component and there's the liquid part. And the salt actually works on the liquid part. And that's what we expected, and that's what we saw here, which was that the high salt diet almost entirely corrected the plasma volume deficit that we saw and increased that in the control subject. But if you look at the red cell volume on the right panel, it made no difference. And it makes sense, right? It's not obvious to us, at least acutely in the short term, that red cell mass, the blood cell production should increase with sodium, but the liquid part of blood did. As I mentioned, we looked at standing or upright plasma norepinephrine levels, and we use this as a crude marker of sympathetic nervous system tone. And that's because norepinephrine is a neurotransmitter in the vascular part of the sympathetic nervous system. And what we found is that it lowered the high salt diet, lowered the upright or standing plasma norepinephrine level compared to the low salt diet in the POTS patients and in the control subjects. Again, even on a high salt diet, the POTS patients still had, the ones we studied, had higher levels of plasma norepinephrines or higher levels of sympathetic tone that we're estimating than did the healthy control subjects on the low salt diet. So it didn't normalize things fully, but it moved things in that direction. And it is worth noting that these POTS patients would qualify as hyperadrenergic by many definitions. So I struggle with the term hyperadrenergic POTS and neuropathic POTS as a classification because I think there's a lot of overlap and limitations. But if you look at the POTS patients on a low salt diet here, the upright or standing plasma norepinephrine level averaged over 1,000 picograms per milliliter. Generally speaking, anything over 600 or 700 is considered elevated. And those thresholds are often used to define hyperadrenergic, certainly within a study. So these patients that we improved were actually hyperadrenergic to begin with. And we made them less hyperadrenergic, although one could argue they're still hyperadrenergic afterwards. This slide shows some of the heart rate data. When lying down on the left, there was a slight decrease in heart rate in the POTS patients, not so much so in the control subjects. Not a huge difference. But if you focus on the right panel, there's actually two bits of data. The left part of the data is actually the upright heart rates. And you can see that there was a significant decrease from low salt to high salt. Low salt here are the open squares, the high salt are the solid squares. In the control subjects, it didn't quite reach statistical significance, but there was a decrease as well. And because the upright values decreased, but the lying down values didn't change much, there was a big difference in the orthostatic tachycardia or the delta heart rate shown in the far right here. So the high salt diet decreased the orthostatic tachycardia.
Satish, could you clarify for people what the salt was? How much salt was the high salt and how much salt was the low salt?
Sure. So these were extreme diets. So the low salt, we were aiming for 10 milliequivalents a day, which is, almost absent. It was so low that we couldn't actually measure to document that it was absolutely that low, but it was a very, very, think of the blandest possible food you can have. And that's what we had. Having said that, the kitchen did a reasonable job. It didn't taste quite as bad as I thought it should. The high salt diet was 300 milliequivalents a day, which is an aggressive salt intake. Now, we didn't have people add salt. We didn't use salt tablets or things like that. It was we actually had a metabolic kitchen created, but it was a very aggressive high salt diet. And again, as I mentioned earlier, the goal of these treatments is to make people feel better. And unfortunately, our data collection and storage on the symptom ratings wasn't as good. So we're missing a bit of data. You see less data points here than in the prior slides. But quantitatively, there was a decrease. So it didn't quite reach statistical significance from low salt to high salt. But you can see that from the data we have, there was an improvement or a reduction in symptom burden in the POTS patients. Not really in the control subjects, but again, they weren't that symptomatic to begin with. So the summary of the dietary salt study was that a high salt diet increased plasma volume in POTS patients. It decreased the plasma standing norepinephrine levels. It decreased the orthostatic tachycardia. It didn't fix the POTS patients, right? I mean, it didn't make the POTS patient look like, a healthy subject, but it shifted everything in the right direction, at least in the parameters that we were looking at. So there's been a study in the last couple of years on oral rehydration solutions, so I thought it'd be worth mentioning that. So some of you may be familiar with this. Some of you may be familiar with this in terms of your young kids or babies, but these are solutions that consist of electrolytes, primarily salt, as well as sugar. And the World Health Organization made them widely available to treat diseases like cholera, like really bad diarrhea in many parts of the third world. And in fact, versions of this are available on the US market to treat babies with diarrhea. And the principle of using, in addition to the sodium, having glucose in the solutions that you drink is that there are transporters in the gut that transport sodium with the glucose. And so the theory is the absorption of the sodium may be better with the glucose in tow. And so Dr. Marvin Meadow from New York Medical College, a colleague of Dr. Stewart's, published this paper back in 2019. They used a model, it was an acute study. It wasn't a lot. I mean, I'm not sure that our study of 1 week here, 1 week there is long-term, but this was a shorter single session at a time study. They use lower body negative pressure as their model of orthostatic stress instead of standing or tilt. But you can see here, just looking at representative samples, that compared to the patients that went into the lower body negative pressure box and then had suction applied, sucking blood into their legs and effectively mimicking the standing stress, compared to when they fainted, the pressure dropped, is what we're showing here. Both intravenous saline, so salt water intravenously, and the oral rehydration solution provided more support. They lasted longer before the patients fainted. Now, you can say, well, but the patients still fainted, and that's true, but one of the interesting features of these lower body negative pressure boxes are that you can impose enough stress that you can make anyone faint. So sometimes the key isn't whether they faint or not, but it's how long they can hang in there before they faint. And so this was considered a positive response to the oral rehydration solution and the saline compared to neither. That was just a representative example slide, but overall, the patients with POTS had reduced orthostatic tolerance, or LBNP tolerance, compared to controls, as you'd expect. But they concluded from this that oral rehydration solutions may be a convenient, safe, and effective therapy for the short-term relief of orthostatic intolerance. I mean, I think this study provides sort of foundational data that it may be a reasonable thing to try. Obviously, we'd love to see, that's the first thing. The second thing is I believe the study was mainly in kids and young adults, which is a significant portion of the POTS population, but not testing the spectrum of ages. But we'd love to see sort of the study over time and really assessing symptom burden, which is what we want to improve in many of our patients. So the next bit's going to be on some compression garment work performed by Kate Bourne, a PhD student of mine here in Calgary. This isn't so much about increasing blood volume as redeploying or shifting the blood volume. And so this was a proof of concept study using a segmental compression garment. It's not something that people would wear in the real world. The garment that we used in the lab was made of neoprene and Velcro. Honestly, it was butt ugly, but it allowed us to look at compression of just the legs, simulating sort of knee-high or calf compression garments. It allowed us to look at the abdomen and upper thigh as well as the combination to see if there were real differences with compression overall, or if certain segments played more of a role than others. So our primary goal was to see if compression helped. And so the study involved having patients undergo a series of 10-minute tilt tests in the lab with these different compression configurations. And really, we were looking at the heart rate. And so you can see here the heart rates on average Before the tilt, these are the negative numbers, -4, -3, -2, and then the positive numbers are, at 70 degrees head up tilt, so simulating standing. Many of you have probably had tilt tests. And with no compression, in blue, you can see the heart rate went up quickly with tilt and then continued to go up. And the average heart rate at 10 minutes was about 110 beats a minute. With the full compression, the heart rate still went up on standing. Remember, orthostatic tachycardia, heart rate increase on standing or with upright tilt is not abnormal. It went up, but then the increase over time as these patients stayed tilted was significantly blunted and decreased, with the compression. And this shows some of the heart rate changes. So the panel A on the left is the delta heart rate or the orthostatic tachycardia, the change in heart rate. And you can see that overall, on average, it was much higher in the no compression group, and it was blunted in the full compression group, although there were some people shown here in red who had very low levels in both cases, levels that certainly wouldn't meet the traditional 30 beat increase of POTS patients, even without compression. They didn't benefit that much, and we have some data showing that more clearly. On the right, we see that, again, the compression didn't do much to heart rate when people were lying down, but it really blunted or prevented some of that increase on standing. And we wanted to understand why. So this slide shows two things. One is, in addition to the no compression versus full compression, we actually have the dose response, if you will. We have no compression in blue, the calf only, leg only compression in red, the abdomen and upper thigh compression in green, and then the full is both the leg and the abdomen, upper thigh. And you can see that the increase in heart rate, the orthostatic tachycardia, decreased in a dose-dependent fashion the more compression you did. So full compression was the best, the abdomen and thigh was second best. The leg compression helped a little, but really not a lot compared to no compression. Part of the effect, we always say that, POTS is the excessive increase in heart rate, the excessive tachycardia in the absence of orthostatic hypotension. And that's true because significant orthostatic hypotension requires a drop of 20 millimeters of mercury. But there is, in our patients, there was a subtler, a smaller drop in pressure. This is in systolic pressure of about 10 millimeters of mercury with no compression. The leg compression really did nothing for that. But when we got to the abdomen compression, we started decreasing that. And with the leg and abdomen together, it was decreased a little bit more. And that may be part of what's driving the heart rate. There's not severe orthostatic hypotension, but there may have been mild orthostatic hypotension that we were able to blunt. When patients get tilted up, fluid shifts from their chest to below their chest, less blood comes back to the heart, and that can drop their stroke volume. And we see that in panel C here, where the stroke volume dropped a lot with no compression. Again, the leg compression did very little, but the abdomen and the full compression decreased that drop in stroke volume. It significantly blunted that drop. So it didn't increase the stroke volume, it just prevented things from getting a whole lot worse. These slides show orthostatic index. It's a fairly clever way of presenting data that Robert Holtke, who's an autonomic specialist in West Virginia, and the last I heard was a jazz musician in New Orleans post-retirement. He created this, and basically what it did is it says, okay, well, we want patients with POTS, a good result of a drug or treatment in someone with POTS would be to either lower the heart rate or have them standing more or both. And so he took the inverse of the heart rate, which is the RR interval, so basically the RR interval, the bigger it is, the lower the heart rate. So that's a good thing. And the longer you can stay up, that's a good thing. And sort of did the integral of the two. And so the area under the curve of the orthostatic index is sort of the multiplication of the integral of the time on tilt that you're able to stay up and the RR interval, in this case, up to 10 minutes. And what we found, it fits with the other things we found using just heart rate measures or just stroke volume measures. And that is that the orthostatic index was lowest for no compression, was highest for full compression, and was somewhere in between, with the abdominal only compression second best and leg only compression barely better than no compression. Right, so these findings all consistently are telling the same story. And importantly, symptoms tracked along, right? So the patients with full, these were the same patients that did all four of these modalities. So the same patients with the full compression reported less symptoms when upright using the Vanderbilt orthostatic symptom score than with no compression, and it decreased in a graded fashion, with abdominal and thigh compression being better than leg compression, but not quite as good as everything. And if we look at the change in heart rate and the VOS score, there was actually a pretty good correlation. Right, so that's not to say that symptoms are all about the tachycardia, but this suggests that this approach to improving the tachycardia was also associated with a decrease in these acute tilt symptoms. I alluded to the fact earlier, there are some patients that actually didn't meet POTS criteria even with no compression. When we sort of broke that out and looked at response based on the baseline increase in heart rate, what we found is that the worse the patients were at baseline, the more benefit they got. So the people with a lot, really high levels of orthostatic tachycardia seem to still had the highest levels afterwards, but had the greatest benefit as well. And that's what's shown here in panel B. So the worse you were to begin with, the more benefit there was to be had with an aggressive compression garment strategy. So this is a proof of concept study. We want to be quite clear about that. I personally believe the compression garments do work, but the study to see if they work in the real world is one that that's Kate's next study. That's the study that's just started to see if this will give us the same results in people's homes and in their day-to-day lives and in regular practice. But this shows the concept of compression anyway can be very helpful to patients with POTS. A few words about exercise training. I'm not going to belabor the point, but it does play to this blood volume issue. Many of you have probably heard about the pros and cons of exercise in POTS. It's a very difficult thing to start doing. There's a huge exercise intolerance component that's intrinsic to the disorder. But there are patients that historically have seemed to do better with exercise, and that's been borne out now in at least 3 studies from different centers that we've seen. So this slide is from the Dallas study that was published over a decade ago now, where they took patients and did really heroic assessments of physiology, as well as simple things like quality of life before and after a 3-month program that sometimes took longer to do. But one of the things that they measured was blood volume, and they looked at the total blood volume, which we showed, and plasma volume. And what we see in both cases of total blood volume and plasma volume is that there was an increase with exercise. Again, similar to what we found, it didn't normalize the patients. It didn't get the patient's blood volume to the level of the control subject, but it did move things in that direction. And that's actually something outside of POTS has been well recognized, that exercise, both an acute bout, although that's a transient effect, and regular exercise does increase blood volume. And part of that mechanism relates back to one of those things that we were looking at in the first couple of slides, looking at the renin to aldosterone conversion. So if you look at the aldosterone to renin ratio, the amount of aldosterone produced for a given amount of renin activity, that's actually been shown to go up with exercise. And in fact, that was shown by Chi Fu in another paper related to this study. So exercise can actually increase blood volume as well. So this lists some of the benefits of exercise training. I won't go into them all. Obviously, if what patients want is improved quality of life, but one of the mechanisms here is an increase in blood volume. We can talk about, my approach, my advice for patients when doing it. The important things to recognize are it's not easy and it's not fast, right? This is it takes a big commitment and a long-term commitment. Many patients I have benefited from this, but it doesn't occur quickly. So for the last bit, I just want a few words on some medications for POTS. They're different. We obviously recommend salt and water. We've talked a little bit about that. I'm not going to say too much about fluticasone or octreotide. If there are questions, I'm happy to answer that. I just want to say a couple of words about intravenous saline, and which I'm fairly confident you've all heard about, and DDAVP, which some of you may not have heard about. So there's been data now for almost 25 years that acutely intravenous saline can decrease orthostatic tachycardia a lot. And this is a study published by Josh Jacob when he was a fellow at Vanderbilt a long time ago. He's now head of medicine in Tel Aviv in one of their departments. But with placebo, you can see that there's excessive orthostatic tachycardia. The heart rate increase shown on the left is above 30 beats a minute. If you look on the right, after they gave at baseline, it's that high, but after saline, it drops in half. It's probably a 15 or 16 millimeters of mercury, or 15 or 16 beats per minute. So in essence, it's normalized the heart rate increase on standing. It's normalized the orthostatic tachycardia acutely. So this is a liter of saline over an hour. So there's no doubt that this can be useful if someone is in acute distress, right? As a one-off therapy, POTS, as we've shown, POTS patients, many of them, not all, are hypovolemic, have a contracted blood volume state, and saline acutely can fix that. It's not a long-term fix, but acutely fixes that. And that's reflected in different guidelines. This is from the Heart Rhythm Society position statement on POTS from 2015, I believe, where it was felt to be reasonable to treat POTS for short-term clinical decompensations with an acute infusion of up to 2 liters of saline. My advice is often if you end up so bad that you end up in the emergency room and they're trying to figure out if the doctors are trying to figure out if you need to be admitted or not, before making that decision, my advice is usually to try to get them to give you a couple of liters of saline, because in many cases, I think in most cases, you might feel well enough not to have to be admitted to hospital. What's more controversial is the regular infusion. So acutely, a one-off bit of saline is good. Well, if that's good, the problem is it doesn't last. The problem is, can we do it repeatedly to get that ongoing benefit? And that actually is not recommended. Class 3 is, don't routinely do it. And the concern is potential harm, and specifically, it's over the intravenous access. So when getting a single dose of saline, one would put a peripheral intravenous catheter in the arm in the emergency room or an infusion clinic. The problem is every time you do that, you clot off that little bit of vein, and it becomes harder and harder to do. And people getting saline long-term can go down the path of going from peripheral intravenous catheter to a PICC line to a portacath or a central line, and they have their own concerns and complications. There isn't a lot of data on this. There's a couple of studies that have been published on this. Jeff Moak is a pediatric cardiologist at National Children's in Washington, and they published a series, and these were presumably kids who were very symptomatic that they did give saline to for varying amounts of time, but chronically. And the vast majority of his kids had PICC lines, not ports. So PICC lines are arguably kinder, gentler long-term catheters, but usually you have sort of 6 weeks to 2 months, not usually longer than that, out of them. And what they found that was concerning is the rate of complications weren't trivial, and actually seemed higher in the groups in his patients and in the patients with autonomic problems, POTS, things like that, compared to all comers in the hospital. And the reasons for that weren't clear, but that's one of the two papers available. The other is a series that was published by Blair Grubb's group in Toledo. And the experience was a bit more positive. It had about 50 plus patients. This is a retrospective look. They weren't doing it just for the study. And what he found is that there wasn't actually a very high rate of complications. But the interesting thing in the Grubb study was that almost half the patients were off the saline in under 3 months. So it really was a short-term bridge for a lot of people. And the overwhelming majority never required anything beyond peripheral intravenous lines. As I said, that's actually, in the short term, you can get away with that until your veins collapse and you can't get intravenous catheters anymore. And that's when people sort of slide over to PICCs and ports. But compared to the experience in the MOAC study, most of the patients in the Grubb study had peripheral catheters and were on, and a good number were on for a very short period of time. So I still hesitate to recommend it if we have to put catheters in. If you're going to do it, I think you have to proceed with caution and focus on short duration of therapies and trying to avoid central lines for the saline. Finally, DDAVP is a short acronym for desmopressin acetate. It's a modified version of arginine vasopressin, which is the natural antidiuretic hormone. So it causes free water retention. It causes your kidneys to hold on to water. And in fact, it's on the market, I believe, to treat enuresis in kids. So basically little boys that wet their bed. So we thought, if used in little kids, it can't be that bad. It may help expand plasma volume in POTS patients. And so we studied that acutely in one of our short-term 4-hour trials at Vanderbilt. And taking DDAVP 0.2 milligrams with 16 ounces or half a liter of water helped. As you can see here, it lowered the standing heart rate, it lowered the orthostatic tachycardia, it improved symptoms. The one concern is that by retaining free water, you can actually dilute your sodium in your blood down, and you can cause dangerously low levels of sodium. So there are different approaches to using it. I typically have my patients use it as a special event drug. So, one frustration that patients have shared with me is that the POTS is unpredictable. They have trouble making plans to go out with friends on a Thursday night to a movie. Well, now we all have trouble with that because of COVID, but before COVID, had trouble making those plans because they didn't know how they'd feel. In those cases, if you were to take the desmopressin Thursday afternoon with water, we have data now that that'll buy you several hours where your blood volume will be plumped up a bit and you can feel better, and anecdotally that has certainly worked. Blair Grubb in Toledo has taken a different approach to it, where he's actually used it as a daily treatment at bedtime. Patients will take 0.2 milligrams at bedtime, and he actually has them have the patients have their sodium checked weekly in the lab and have that phoned into the office. And what he told me was that for the most part, he didn't have major problems. There's only one person that actually had fairly significant hyponatremia or low sodium, and that's someone that felt so good with the one tablet that she thought 4 would be better. And so there's just a caveat that you have to be careful that, just because a little is good, more can be dangerous with some of these drugs. So I'm going to stop there, mainly because I have no more slides, but also because Lauren would have cut me off anyway, and I'm happy to answer questions.
Me? I would never cut you off. What? So there's a lot of really, really good questions, and some of them echo things you already said, but I think they're worth repeating if a bunch of people are asking about them. So somebody asked a question at the very beginning about the desmopressin you just mentioned at the end, and they asked, what is the type of dosing that is safe to use without risking hyponatremia?
So everyone's different, and so I'm not sure there's ever no risk, but The dose we've used is 0.2 milligrams daily, and we used pills in our study. It also comes as an intranasal preparation if you prefer that to pills. For the most part, that dose has been safe. Having said that, if you're going to take it, I still recommend getting your potassium, or not your potassium, your sodium checked, probably a little more frequently in the beginning, and then, perhaps it can be spaced out a little more, but have that checked over time. Hyponatremia is one of those things that can be asymptomatic until it gets very severe, right? But it's very easily checked, and you can sort of, turn the boat around very quickly if you catch it early.
Yeah. If someone was tracking urine sodium levels to see if they're getting enough salt, is there an ideal that you aim for, and is there an upper limit to what you would want to see, like too much?
Yeah, so we in our study, in theory, they should have had a level of 300, because the milliequivalents you take in should be what you put out. I think it was actually closer to 260 or so, so we didn't quite reach our target. The only study in terms of, so I don't routinely use 24-hour urine sodiums, although it can be used to track how much sodium you're getting in if your diet's stable. There's one study, and I think it is in a pediatric population, but one study out of China, I believe, where 160 milliequivalents was the magic number, where if patients were below that, they seemed to symptomatically benefit from augmenting their sodium, and patients above that, they did not find that same benefit. Like I said, I don't typically do the 24-hour urines unless there's a major disagreement between my impression of how much salt the patient's taking in and how much salt the patient thinks they're taking in, and it's a way of objectively determining that.
Okay. Can you comment on what is preload failure, and how does this relate to blood volume in POTS? And you probably know that it's, I'm going to guess this patient sees David Systrom, or their relative does, because Dr. Systrom is pretty much the only one that uses that term, but it has a medical meaning. So
yeah, so I'm not sure I've used the term preload failure, but this is it's all different ways, I think, of addressing the same thing that we're talking about. That when he's talking about preload, what he's talking about is cardiac preload. How much blood, or it's actually filling pressure, is coming back to the heart, right? The heart, Wouter Wheeling, an autonomic physiologist from Amsterdam, once published a paper saying the heart can't pump blood that it doesn't see, right? So the blood needs to come back to the heart for the heart to pump it out. And in fact, what we're doing here is trying to address preload failure. So the blood not getting back to the heart. In fact, different things I talked about today do that in different ways. So the increase in salt is to increase the overall blood volume to get more blood coming back to the heart. And we all recognize that the problems in POTS patients are more acute when they're upright than when they're not. And that could be because their blood volume is just so critically low that they fall below a threshold, or it could be that they may also shift more blood. They may pool more blood in their belly, for example, that's not getting back to the heart, and that may be where the compression comes in. So these strategies we talked about today would be strategies that would help with the preload failure term that David Systrom talks about.
So you did mention this when you were talking about the Vanderbilt study, that the SALT study, but can you just discuss, just emphasize a little bit, should people with hyperadrenergic POTS increase their salt? And the question specifically says if it raises their blood pressure.
So, I would be, the short answer is I would give it a try. Because one of the things with hyperadrenergic patients, probably POTS patients in general, but certainly hyperadrenergic patients, is that the blood pressure can be all over the place, right? And I think, if you're more reactive, your sympathetic tone jumps up, your heart rate and your pressure can go up transiently, and you don't want to overreact to that. The theory behind the expanding the blood volume approach is that if your blood volume is very contracted, one of the body's attempts at compensation, the compensatory response, is to increase sympathetic tone. That may then increase the heart rate, and at times the blood pressure excessively. And by reversing that process, by expanding the blood volume, you decrease the need for the body to increase sympathetic tone. And that may actually paradoxically lower the heart rate and blood pressure. Now, blood pressure is really, really complicated. I mean, people have been studying this for close to 100 years, and there are different mechanisms at play. So in your specific case, if you're taking a high salt diet and over time, not a reading or two, but over weeks to a month, your blood pressure has gone up and is staying up and is quite high, then you may need to back off on that a bit. But as a strategy, it's not necessarily wrong. And the other thing to remember is that blood pressure, high blood pressure as a problem, is a chronic problem. It's not so much the blood pressure that you have today is going to cause you problems today or tomorrow. But if your high blood pressure stays high this month, next year, the year after that, over time that causes vascular damage. And that's what you want to avoid. So it's not that you need to rush into fixing it tomorrow, but you don't want to ignore it either.
Can you explain the concept of pulse pressure and talk about what narrow pulse pressure means in the context of hypovolemia?
So when you have your blood pressure measured, it's usually reported as two numbers, right? Something like 100 over 60. And the 100 is the systolic blood pressure. The 60 is the diastolic, or the bottom part of the blood pressure. And the pulse pressure is the difference, right? Literally is just the systolic pressure minus the diastolic pressure. It's the amount that the pulse moved from bottom to top each time. When you are hypovolemic, you have less blood to move that pressure around each time, right? So often people that have a low volume, that are volume contracted, will have a lower pulse pressure. I'm not sure it's certainly not the be all and end all measurement, but often the pressure will be low as that volume gets lower.
We definitely hear a lot of patients talking about when they have a narrower pulse pressure that they're feeling more symptomatic, they're feeling kind of crappy.
And I think that correlates. The other measure that we look at, that we presented in the compression study, is stroke volume, right? So stroke volume is, these are all sort of fancy sounding terms, but all stroke volume is every time the heart beats, it's how much blood is leaving, right? How much blood leaves the heart every time. And if you think about it, that's what makes up your pulse pressure, right? It's like you have a baseline, level of tone, that's your diastolic pressure, and then you get this whoosh of blood coming through, and depending on how much whoosh you have, your pressure goes up more or less, and that's the pulse pressure.
So here's a good question. Some doctors have used albumin infusions to try to expand blood volume. Can you share your thoughts on that and sort of what most of the dysautonomia experts think about that?
So I know some doctors have done it. I think there may even be a study going on, a small study going on now about this. To date, there's really no published data on it, right? So the challenges with albumin.
Maybe tell people what albumin is first, maybe.
Fair enough. So albumin is a human blood product, right? It's a protein that we have in our blood, right? So the challenges with albumin are that literally you're taking someone else's human blood product and infusing it. You're trying to do the same thing you're doing with intravenous saline, which is to expand the blood volume. In theory, the salt in the salt water will dissipate, right? So it's in the bloodstream, and then the body does things and takes it out of circulation. Protein in the fluid, in theory, should linger longer, should last a little longer, is the theory behind it. I think most, I certainly would prefer not. I mean, if I'm going to die without someone else's blood products, I will take it, right? I mean, absolutely. But if there are other choices, there's various risks to receiving blood products. So unless you really need it and there's no other choice, I think we have to look strongly at other options. Like I said, right now there's no data that it's better than other approaches. That may change, right? There is at least one study I know that's supposed to be going on looking at that.
Okay. Can someone have hypovolemia and a small fiber neuropathy? Are these subtypes distinct? I know the answer, but you can explain it.
Yeah, so the answer is yes, you can have lots of things, and the real challenge with subtyping, and for those that have heard prior talks that I've given, when the issue of subtyping or what type of plots do I have comes up, I usually refuse to answer the question and argue that we're not ready for the subtypes, and the reason is precisely this issue, right? And that is that the stage we're at is we can look at different features and try and test 10 people, 100 people with test A, B, C, D, and E, and we can say, well, A is abnormal, B is abnormal, C is abnormal. And if A was, looking for small fiber neuropathy, you say, okay, you have neuropathic POTS. And then if B is looking at blood volume, you say you have hypovolemic POTS. And if C is looking at norepinephrine levels, you say you have hyperadrenergic POTS. The problem is that these groups overlap. I mean, I'm a big fan of Venn diagrams, so this is great for me, but these are all overlapping circles. These are overlapping Venn diagrams. It's not distinct, right? So one can make an argument, and this is a theory, I don't know this, right? But one can make an argument that if the neuropathy is affecting, say, nerves affecting the kidney, that could actually affect some of these hormones and affect hypovolemia. We know for sure that some patients with hypovolemia, as a response, in fact, that's what we showed in our dietary salt study, as a response to the hypovolemia can be hyperadrenergic. But not everyone that's hyperadrenergic has hypovolemia. So we're really not ready to say you have this type of POTS or that type of POTS to the exclusion of others, unless you've actually done a detailed assessment of all of those things.
So then the next question is from a few people, should you try to get blood volume testing? Should this be done, or should you just sort of treat, assuming that you have, that salt and fluids will help you?
So I am, it's a good question. From a practical point of view, I actually think that there's some value in trying to understand the blood volume mechanism. Not everyone has it. In the last few years at Vanderbilt, I'd estimate somewhere around 75 to 80% of the patients had a low blood volume. So it's common enough, but not universal. Since moving to Calgary, I actually have no way right now clinically of assessing blood volume. So I've learned to function without it. And we try and treat everyone with it. I think where it's useful isn't necessarily at the initiation of therapy, but if you've initiated therapy, you're doing the high salt and water aggressively, and things have improved, then great. It's when things haven't fully gotten better and you're debating whether to augment with treatments like fludrocortisone, which has its own potential long-term risks. That's when I think it can be helpful if it's available, right? It's an extra piece of information. I mean, one of the challenges with POTS patients is POTS is a syndrome. It's not necessarily one thing, it's a bunch of things. And sometimes it's helpful to know more about the individual, right? But I think it's reasonable to start with sort of standard approaches. And when those don't work, that's when you really want to sort of take a closer look.
Mm-hmm. If a patient didn't have hypovolemia, would you still recommend increasing salt and fluids to treat POTS symptoms?
But like I said, I don't usually assess it up front. So,
if you knew in a theoretical way, if you knew that, would you still think that salt and fluids would be worth a try?
So I think the water, like getting in a fair bit of water, is probably not a bad thing, for a bad way to start regardless. I think the salt isn't a bad thing to try. I think it's less likely to work, but it's probably not a bad way to start regardless, right? But I think it's less likely to work if your blood volume is actually already okay.
What level of compression do you recommend in compression stocking kind of garments?
So I guess more important than level is wear. So I'm a big fan. I think you have to, if you're going to do it, you have to get to abdomen and pelvis compression. And to the point where the knee-high stockings, I think, are a waste of time, unless you're trying to prevent blood clots. Like if you're worried about blood clots and you're traveling, go ahead. But for fluid shifts, I wouldn't even bother. I used to routinely prescribe 30 to 40 millimeter mercury garments. They're hot, tight, itchy, and ugly. They're a pain in the ass, both metaphorically and literally. I mean, they're tight. They're difficult to get on. They take a high level of commitment. I have patients that use them because I don't have anyone that loves them, but I have patients that use them because they allow them to function. What I've taken to the last few years is using a kinder, gentler alternative. So I'll often now start with athletic wear. I'll often tell people to go to a sporting goods store and purchase triathlon tights or high-end runner stockings, which are about half as tight. They tend to be, the high-end performance stuff tends to be in the 15 to 18 millimeters mercury compression. So not as tight, perhaps not as much compression. The flip side is they look nicer, they're more comfortable, and perhaps people will be more likely to wear them. And if they use that and that's enough, then that's great. If they use that and they think they may help but need more, then that's when I go on to the medical grade compression. The other thing that there's absolutely no data for, so take this for what it's worth, we do want to study this going forward, is that in the summers, certainly when I was in Nashville, but even in Alberta summers, patients will tell me they just can't wear the full length stockings because they overheat. And obviously lots of POTS patients don't tolerate the heat. And so my backup suggestion are Spanx or body shaping garments. Now, I say Spanx because I'm not smart enough to know all the brands. Spanx doesn't give me a dime, unfortunately. So, you know, if you want to use a competitor, please feel free and go ahead, right? But the idea is that I just want, you know, a garment that's going to provide squish to the abdomen and pelvis. So basically, if you get rib cage to upper thigh, that's the focused area. And that leaves, especially when it's summer, it leaves more skin area that's uncovered that we're able to sweat and you don't overheat quite as much.
Can birth control medications help increase blood pressure?
Can they increase blood pressure?
Or maybe more broadly, can they improve POTS symptoms?
Yeah, so I'll answer the question two ways. You know, yeah, so I don't know if it's still used as much now, but Yaz, Yasmin, Ocella were three birth control agents that actually did the opposite. You know, there's not good data on it, but I'm pretty convinced that they actually make POTS symptoms worse. And the reason is because the progesterone, most birth controls have an estrogen agent and a progesterone agent. The progesterone agent in those drugs is a drug called drospirenone, which is an analog of a drug called spironolactone, which is the opposite of aldosterone, right? So it actually works on the aldosterone receptor to block the sodium retention in the kidney, right? So if patients are on that, the first thing I'll try and get them to do is switch to a different birth control agent that doesn't have the drospirenone agent. More broadly, can birth control help POTS symptoms? Certainly a lot of POTS patients will say that their symptoms get worse around the time of their period. And in fact, there's some data where we just had patients and healthy subjects rate their lightheadedness at different phases of the menstrual cycle. And the pattern was identical between POTS patients and healthy subjects in that it peaks around menstruation and just before and mid-cycle, it tends to be better. It was amplified in the POTS patients. So the POTS patients at every point in the cycle were more lightheaded than the healthy subjects, as you might expect, but that pattern was there. And so some patients find the birth control agents that decrease the frequency of their periods. So there's some agents where you have breakthrough periods every 4 months instead of every month. It doesn't necessarily make their symptoms better when they have their period, but they have less of them.
Mm. So I'll take one last question, and this one's a doozy for sure. It's the basically what you've spent your career trying to figure out. So we'll give you like 2 minutes to answer it. What is the root cause of the low red blood cells and low plasma in POTS? What do you think? And I know this is a sort of theoretical question, because if you knew the answer, we wouldn't have low blood volume in POTS anymore. But what do you think the essence of this is?
I had trouble putting our finger on it, but the plasma one, I mean, there's various bits of data. It's just been hard to pin down that there may be something that's not quite right in the renin-angiotensin-aldosterone system, right? And we've wondered whether there's issues with angiotensin 1 receptor responsiveness. right? So you're not producing the aldosterone properly. There's a little bit of data from a study a colleague did at Vanderbilt where they gave angiotensin II infusions, and the POTS patients actually had less of a blood pressure response to it, suggesting there may be something there. And I know Lauren's very interested in some of the autoantibody work, and one of the things that David Kem has looked at and we published is that in addition to the alpha and beta receptors, there's he found some POTS patients actually had antibodies to the angiotensin I receptor, and it's possible. Again, these are all different groups and different bits of data, so it's not all in the same people, but it's certainly possible that maybe part of the reason for that is something affecting the receptors, but it could be exogenous like an antibody as opposed to something they were born with. As for the red cell volume, that's a more interesting question because you're right, the red cell volume tends to be down as well. The explanation for that might be a concept that's been referred to as the kidney is a crit meter, right? So the kidney actually is an organ that uniquely has a role in both red cell production through the hormone EPO, as well as plasma volume regulation in terms of the salt retention stuff that we've focused on with aldosterone, for example. And it's a bit hand wavy, but it may be that it regulates the EPO levels. So if your plasma volume is low, if your plasma volume is low and your red cell level doesn't change, then your blood gets thicker and thicker. It becomes like a thick milkshake. And when that happens, you actually have an increased risk of stroke, right? And other vascular problems, but stroke is the most serious one. And so the theory is that when the plasma volume is low, then the kidney over time will decrease the EPO levels to lower the red cell volume to try and maintain the hematocrit. And hematocrit's a simple blood test that you do, but it's just the concentration. So if both are low, the concentration could be the same. I don't know if that's too simple or too complicated. But.
No, that's good. But my instinctive response to that I haven't discussed this with you before, but others, then why don't we give people chronic saline infusions to increase their red blood cells? I
guess the question is, there are some people that have had chronic saline. I guess, that's actually an interesting question, but there may be data to answer that.
So there's a lot of questions. There's over 100 questions on here. I'm really sorry to everybody. We can't get to every single question, but I hope this has been helpful this evening. And